Hello, good morning.
Good morning.
Thank you. Today we'll start from here, right now.
I think we finished this page.
Is this space?
Yes, yes. The spacemaker rhythms we discussed yesterday. This from Epstein anomalies we have to start.
From here,
Yes, yes, yes.
Okay, you can continue.
Okay. So this is the first. So this is the first one. Here, what we can see is this RSR dash pattern is there, along with some T-wave inversion. I think. Actually, to be frank, Epstein anomaly, there are two kinds. One will have a similar to WPW, short PR interval with delta wave. Other one will have this kind of pattern. This I just remember, that's it. If anybody knows how to remember Epstein anomaly properly, they can tell. RBBB, TR, WPW. Okay.
So RSR pattern,
RSR with the T wave, this one.
Another points.
Another will be like a short PR with WPW. Same like this thing. WPW will be there. Okay.
Okay.
This how come we know? Basically, Q waves in lead 2, 3, EVF along with the lateral leads.
Yes.
And this R wave regression will be there gradually. Okay. How come plus septal T wave inversion plus or minus RBBB support it. Okay.
Okay.
Then this is STEMI. As you can see here, ST wave elevation is there in this lead. This is also ST wave elevation. This is a T wave inversion. This is normalization.
Okay. Now PCI within 12 hours.
90 minutes. If they should do it in 90 minutes. If not available, they should do thrombolysis and I think within 12 hours or something like that. I'm not sure what exactly they mean.
12 hours.
Within 12 hours.
Within 12 hours, plan for PCI. And after 12 hours, then we first we attempt to thrombolysis.
Okay, if it is NSTEMI, I think low molecular heparin plus antiplatelet should be good enough. No thrombolysis, no PCI. But once patient is stable enough, they should do a intervention.
If it's stable, just only platelet.
Yes, antiplatelet.
Okay.
Okay. Next is pericarditis. As you know already, there will be a PR segment depression. ST elevation will be there.
Yeah.
Okay.
Upward concavity.
J point elevation, basically.
Yeah. It's a total area right here. Okay.
Here is the image. One more image.
Myocarditis.
Myocarditis, it's a clinical diagnosis. There should not be any angio finding, basically.
Okay. It looks like SBT.
Yeah, that's what it's non-specific findings. You can't say that exactly. Myocarditis by looking at the ECG.
Okay.
Okay.
Atrial fibrillation. There is no POF. Irregular rate and fibrillatory. Okay.
This has some interventricular conduction block actually. Okay, looks like a left anterior fascicular block is there actually. This one. Okay. So If with control ventricular, right? This one. This is this more of it looks more of a flutter only actually.
Okay.
I don't know what is this coarse fibrillatory. I'm hearing for the first time.
Course.
This also AF with it looks like control ventricular rate only. Anybody know about this term? Coarse fibrillatory?
Might be new.
Hmm?
Maybe
No
no.
idea.
No idea.
Here, one thing is in fibrillatory, there's no baseline change only. Whereas here in coarse fibrillatory, some baseline undulation is there. I don't know what exactly it means. Okay. If anybody knows, let them tell.
Yeah.
Next is, yeah, please.
Saw shape.
Sawtooth pattern. It will flutter.
Hmm.
Here they mentioned 2:1. It's slightly difficult. Okay, 2:1.
How to say it? It is 2:1. I was confused.
First count the rate, then it divided into by 2.
Means no. Where is the atrial one?
This is the point.
No, whatever, most likely. One will
Which
be
one? Can you
overlapping.
mark it? Where the
I
two
think
P
one
wave?
will be the overlapping the QRS complex. Here you can see. One, two. What happened? 1 minute. Not able to mark it. So those two are the this thing, fibrillatory wave, flutter waves. Here it looks like a 3:1, but they mentioned 4:1. Next one.
Hey, 4:1. I can get it. Look. There is 1, 2, 3, and 4. Okay, this small one. Like this one is 1, 2, 3,
Okay. So,
and 4. These are the 4. But here I think this is a P wave and this one is a P wave.
yeah, it will be
I
same.
don't understand.
Just after the QRS one, P wave is there.
Yeah.
Okay. We'll go to the next one. This is that sagging ST El Salvador sign. Okay, in lead 4, 5, 6, it's there. Here it is more in lead 2, 3 area. I don't know which are leads we should be seeing for this El Salvador sign.
The digoxin toxicity.
Yes, no. Which are leads we should see? Here it's in the 4, 5, 6 and lead 1.
Actually, they are in the lateral leads, mainly the 4, 5, 6 thing.
4, 5, 6.
Yeah.
In this it is not clear in lead 6 it is there, but it's more in the lead 2, 3.
Actually, the lateral leads, we have to see these reverse stick sign.
Okay.
Most time I see the 5 and 6, they're prominent, more like the 4. Sometimes we can see, sometimes no. But the 5 and 6, most of the time we can see this sagging sign, sagging of the ST.
1 minute, I'll just come. Okay. The next one is they mentioned RV strain. There is a RBBB pattern is there. There is a S1. I think T3 I can make out. Q Q also I can make out. S1 Q3 T3. So basically sinus shaky S1 Q3 T3 for pulmonary embolism.
S in 1, right? And in 3, there will be inverted T and one more thing, inverted T and Q.
Yeah, some ECGs which we saw are only Q3 T3 pattern. Okay. So they can give, they cannot. Sometimes it's most of the time it's based on clinical scenario only we'll be able to make a diagnosis.
Yeah, clinical scenario. In case of a pulmonary embolism, find at the ECG is tough.
I've seen without a pulmonary embolism also so many patients having this S1 Q3 T3.
You see?
Yeah.
Oh, you are lucky. Then you can find in the exam as well if we can get one. Yeah.
Okay. Next one is they mentioned VT.
PT, broad comp.
Right ventricular outflow tract.
It doesn't look like a classical VT.
VT bundle branch block, they are saying. Like then the QRS complex will be the white QRS complex.
It looks more like SVT with LBBB rather than VT, looking at these waveforms.
But I think, oh yeah, this is
tough.
It is tough. Like it's supraventricular tachycardia with LBBB or is ventricular tachycardia with LBBB. I can't.
No, this looks like a SVT with LBBB for me, if you ask.
Yeah, because there is no P wave. I cannot see any P wave in here.
Yeah, there's no P wave, there's no capture beat, no fusion
Yeah,
beat.
this one is a SVT, not VT.
SVT with LBBB, this is.
Yeah, everyone is correct. SVT with why RAD they are saying? I'm not getting it. Why rate axis deviation?
But axis is fine.
Axis normal. Axis normal.
Yeah.
All the positive thing.
Okay. No, I think this
Okay.
thing we are correct, I guess. I don't think maybe there's something known as RVOT tachycardia means we have to read it for that. But otherwise, for all practical purposes, this is SVT with LBBB. Okay. There is a calcification around the heart. Okay. Constructive pericarditis. Rapid white descent will be there in the.
These are the calcification in X-ray in the apex area.
Yeah.
X-ray apex area.
This which is a sign that is Kussmaul sign, no?
Kussmaul.
Yeah. Okay. How will you treat pericarditis?
Pericardiectomy.
Pericardiocentesis.
I think diagnosis.
No.
Diagnosis is by cardiac MRI.
Yeah.
MRI pericarditis is TOMI. Like you have
to cut it.
But one question we read, like the patient has TB and this pericarditis. First we treat with the anti-tubercular drug.
Yeah.
That question is a mistake actually. Because if patient has a calcification, whatever you treat, it's not going to correct the calcification.
Yes. It is a permanent thing. You have to treat active TB first.
Active TB first, then go for this pericarditis.
Yeah. Yes.
Because then
it will disseminate, it will disseminate. When we cut it, it will go to the brain and it will cause
other place. Go to the other system.
Okay.
Similar to that heart only. Like in heart also, we treat the first underlying conditions like strongylitis or anything, any infection.
Okay. Then next one is I think the electrical alternates. It can be LVF, it can be tamponade. alternate one high voltage, low voltage is there. Okay. Electrical alternates. If a patient has a classical Kussmaul, this thing, what is the triad of pericardial effusion?
Sound,
Huh?
pulsus paradoxus.
No, that muffled heart sounds, hypotension, elevated JP. What is the triad?
That chart.
Bex.
Beck's triad, yes.
Oh,
Yes.
Bex.
Beck's triad. Okay, those three is there. It's more of a tamper. Okay. Next question. We'll go to this thing. So J point elevation. We discussed already where all J point elevation is seen.
Hypothermia and one more thing. I think in sometimes we write okay the epsilon sign, and how can we differentiate this epsilon sign and this
Epsilon will have a T wave inversion.
Oh,
T wave inversion will be
T
there.
wave inversion. Yeah.
Yes. Okay. It is seen in hypothermia. It's seen in ARVD. It is seen in after exercise also normally, and it will reverse actually, that one. Even your STEMI will have a J point elevation and benign electrical
Pericarditis.
Pericarditis. Pericarditis.
Normal variant.
Okay. So these are the reasons for J point elevation. Next one is they're showing a bifid P wave. So bifid P wave is seen in mitral stenosis, whereas elevated P wave is seen in pulmonary hypertension.
Pulmonal, yeah.
Pulmonary. P mitral is M. Okay.
Yeah.
Okay. Next one is okay. It is a P pulmonary is there. Next one.
Yeah.
Okay. So, but RV strain is not that significant actually in this. And there is a regression of this thing, R wave, in this also. So, pulmonary stenosis, COPD. They'll give tetralogy of Fallot and all. Boot
shape. Yeah.
I don't know. This is the first time I'm hearing the term Karzweikel length. Yeah, I'll say biventricular hypertrophy.
Large biphysic.
What is this? Karzweikel? Anybody is aware?
No, I don't know.
I don't know.
Okay, I don't think we have come across till now, so hopefully it will not come. For all practical purpose, it looks like a biventricular hypertrophy. Okay.
Like all these are like
LVH is there, RVH is also there. So
yeah.
T wave inversion in 2,3 AVF as well as in V5, V6. So
how to say it? RVH here? LVH I can understand, yeah.
2, 3
RVH
right,
because you have to see the lead 1, 2, 3, the right or the
okay, RVF. Okay, yeah, got it.
Okay, so they mentioned some VHD is also there. It seems in this. Okay, I think it is too much. We should not delve too much into deep. Okay, next one is basically in ASD, secondum type. In case of septum secondum, there will be right axis deviation. RBB with right axis deviation, whereas primum left axis deviation. RBB
deviation, yes.
Okay, so
this is right axis.
Yeah, RBB is there. Some right axis deviation is there, not classical.
Not
like lead 1 is half and half, right?
Yeah.
Proper, not like right axis deviation.
It's
I know
difficult
they
to say.
clinically, but they'll diagnose this on based on echo rather than ECG.
Like yeah, echo, the bubble thing we have to do. Otherwise, yes.
By seeing ECG, RBB is only.
Yeah, RBB is the only thing we can make out actually.
Yeah. If someone asks me what is the axis, I will say normal.
Yeah.
Better said fixed split. Yeah. That also to be
Okay.
frank,
Mm.
I can't make out fixed split and all. Okay. Okay. Next
It will be
one.
tough part in the next exam passage.
Uh, we'll practice. Okay. Left axis LAE. What is LAE?
Left atrial enlargement, I think.
Okay. It is definitely not an MS because it's not going straight till here.
Mm. Small notch arch on the.
Hmm.
Where they can get this
I don't
small
know.
arch?
Aortic arch
Aortic
will be
arch.
very small.
Oh yeah.
Hmm.
Okay. Aortic arch is small. That's what they are trying to see. Okay. Okay.
Mm.
But they are not differentiating which one is this one.
I think the left. Okay. Yeah, I guess.
Definitely some pulmonary hypertension is there. Okay.
You compare with the this one, no? Our core and subu. What do you say? Tetralogy picture, because
Yeah.
there is also a VSD there. Right. Almost similar, just that the right ventricle hypertrophy is far too much, so that it actually goes up.
What is in the second picture? Do you want to say?
Second picture also same only, I guess.
Okay.
But there's a double border, it looks like.
Yeah, it seems double border on the lower upper
There's
part.
the ASD, possibility of ASD being there. Most likely ASD, I guess this is.
Okay.
I don't know. This image, cardiac images are not that. Some of them are good, but not all of them.
Okay. Next.
Okay. This one is also some double heart border. They have already marked. I don't know. A left LAE is depicted by straightening of left heart border and a double heart border. The remaining cardiac celerity is outlined in yellow. Mitral stenosis. That's not mitral stenosis. It is more of a right ventricular hypertrophy is there in this.
Left or right?
Right ventricular hypertrophy is there. I agree, but generally it will be more on the left side. It will not be this much like this. I think we'll.
This has to have associated like AR or something has to be there. Aortic regurgitation, because the apex has gone far too much down. Mitral stenosis, only in mitral stenosis, apex will be not that much down out. Apex is always only out. Fifth intercostal space in a pure mitral stenosis, it will be just half an inch or 1 inch outside the midclavicular line. But this apex has gone far too much down. There has to be associated disease.
Okay. Diaphragm is also slightly pushed up. I think left side. That's why it is making us difficult. There is a problem with the diaphragm. Or he has eaten too much food, I guess. Generally, right side diaphragm is more elevated. So I don't know why left side diaphragm is more elevated in this patient. I think that is the one which is causing the problem. This diaphragm. Generally, that heart border generally will be able to see entire length. Left heart border. Okay. We'll see how it goes. Next one is, we'll go to the next one. If good images are seen, share in the group. That's it. It will be easier. Once we look at more images, if you have a problem, then we'll be able to say it better. So this one has a broad QRS complex. Okay. So P wave is there. Dominant R wave in AVR. Okay. Basically, broad QRS complex in the background of some poisoning, TCA it will be. That's it. Treat with sodium bicarb. Okay. This is hyperkalemic changes. Okay, generally, what is the next step we'll do? This they'll ask in the exam. It is broad QRS complex. P wave will disappear. Tall T waves will be there. Okay, P wave is not there. QRS broad. T wave will.
Give calcium gluconate now.
Yes. Okay. This doesn't have a QRS complex, but tall T wave is there. So it's early changes of hyperkalemia. Next one, we'll go this side. This is a U wave is there. Basically hypokalemia. This is also T wave inversion. It's U wave hypokalemia. Okay. So all three are hypokalemia only. So hypocalcemia, last one long QT. Hopefully they'll mention the QT interval. Then some scenario of short QT they mentioned, hypercalcemia and hyperkalemia.
Yes.
They'll ask this M mode and all in the exams. Because M mode is too much, if you ask me. I'm not sure. I know a lot of places they mentioned.
Imagination.
If someone has a bad imagination like me, then what will happen?
Okay, we'll do it. Anyway, whatever they mentioned, we'll do it. Not beyond this. So basically what happens in an M mode is, they'll cut through the metal wall. 1 minute. Okay. See here, this line is going through. Okay. Tip of the metal wall, they'll be cutting through in M mode. So during systole and diastole, what will happen, we'll be seeing. Okay. Normally, it will open like this, come back. 1 minute. It will go like this, come back and come back like this. Then both the walls, here another wall will be there. Okay. It will come like this. Both the walls will close. Then it will open up again. Okay. It will be closed here. Oh, the opening is atrial diastole. Closing is diastole. Opening is diastole. Closing is systole. Okay. Basically, it will be coming like this. So in case of rheumatic heart disease, basically what it will be is this this is a J. Okay, here what they're trying to show is the hockey stick shaped wall. Okay, hockey stick. Appreciate anybody able to?
Yeah.
Okay, hockey stick shape. Okay, in case of rheumatic heart disease, your mitral valve anterior flight will be hockey stick shaped. Okay, so
Ice hockey one. No?
Ice hockey one. What? Okay. So next one, what they're trying to show, I think this is same thing only. This is also hockey stick only. I don't know what they're trying to show here. So next we'll go to mitral valve prolapse. Mitral valve prolapse. This what? Diastole. Actually, we have to see the problem in this thing systole. It will be open. See, it is not completely closed here. Okay, there's a big gap is there. Okay, normally it will close completely. Like this, it will be. There's a big gap between the two walls. Okay, sorry, not this. This one and this one. There's a big gap is there inside. So there's a regurgitation is there because of that. Okay, that is mitral valve prolapse causing mitral regurgitation. Okay, next here we'll go to the left hand side, second image. This also looks like same only. It is not completely closed here. Okay, here also not completely closed. I don't know why. Okay, but here you can see that the thickness of the LV septum, interventricular septum thickness, actually they are trying to concentrate. It is so big. What is this thing for intervention? We said more than 50 millimeter. What is this thing? Septal diameter should be for surgery.
But I remember 50
for-
only. 50 mmHg.
50 50.
Sorry.
No, 50
Sorry, yeah,
millimeter.
gradient should be 50, yeah.
Okay,
If
so
it
it
is
is
more
a
than 50, it should be
septal
go for
ablation or
myomectomy. Mhm.
myomectomy.
Either alcohol or something given.
Okay, so this is down is the below is the imaging of the same thing in echo. This thing short axis view. Yeah, here also you can see that there's a big this thing. Maybe we should see all the options at least for the questions we don't know. Looking at the questions, we'll be able to understand, I guess. Okay. So in case of mitral stenosis, this opening itself, see here, opening is big. Okay, mitral valve when it opens here. Okay, here there's very narrow opening is there. I think this one. Okay, only this much opening is there in this.
Here is the M shape will be lost, right?
No, M shape will be lost. There's no M.
Hmm.
Okay. In case of mitral stenosis, I think we should collect better images. If this kind of question comes, we should have a better images actually to understand it, to answer in the exam. And in the exam, they'll give classic images only. They'll not give images which are difficult.
Hope
Okay.
so.
Here, okay, we'll go down. RCP Insider will tell us better. Okay. So next is a mode at the aortic mitral valve only. Again, mitral valve they're given. I don't know what they're trying to say because here nothing is seen. But here looks like there's a myxoma is there down.
This one is myxoma.
Yeah, this is myxoma, but I don't know what they're trying to say here.
They want to give this a diameter or something.
No, see
Oh,
what they're telling is in systole, diastole, everything myxoma is coming into the wall, so there no gap is seen. As you can see that there is, so this is myxoma which is coming into the this thing. So they're not able to appreciate anything filling.
Okay. Yeah,
Okay.
this one.
Okay. Next, aortic stenosis. Go up. Up. No. Up. Okay. Basically, mode at the aortic valve. Aortic valve will open like this. Classically, they should open fully, then close it completely. Okay, that's how it works in case of aortic valve. Here, they should have shown a normal this thing. Then it would have been easier. As
Yes, this is confusing.
yeah. So here you can see that there's not much opening, like similar to MS only. Opening is not that much. Generally, as they mentioned here in the figure, it will come like this, go, then close. Okay. In case of aortic stenosis, it will be very narrow. Okay, that's what they're trying to say here, basically.
But in here, in picture, the diastole is not like in a good thing, right? The systole, diastole, we cannot differentiate which is systole.
No, that I have to differentiate. That's why they have given PQRS. Okay. But I don't think it should be for this. Should be for first of all for MRCP. It is more of a cardiology trainees. Which MRCP student is going to do echo and identify these problems. They have a BSc for that actually. A lot of people do basic BSc, basic echocardiography course there. Okay. So this is an left atrial thrombus, basically. Okay, nothing else I can make out. Maybe somewhere, if I imagine more, I can make an ASD. Thromboembolic features, left atrial thrombus.
But where is the right atrium here? Can you say?
Right atrium is quite dilated.
Okay, but it is, the valve is
most-
open. Okay.
No, then it is ASD only, I guess. RA will never be this much big without this thing.
Yeah.
It must be an ASD only then. So, or it might be MS also. Here they mention MS. If the MS is there, LA will be dilated, then RA will be dilated, RB also will be dilated. Okay.
The section is not good actually.
Yeah. Actually, it's not
a good start. Chalo, next.
We are doing a lot of imagination. And then we might have good Picasso drawings. Okay. This is a standard pericardial effusion. Okay, as you can see here. Okay, it's difficult to say tamponade in this, but it's an effusion. Okay. Okay, here you can see the dissection is there. It's a nice dissection below that. And section height. Okay, fine. That's it. We'll go
Which one is dissection? Can you
This-
show again?
I
this.
think the outer last
I
one.
think there is
Okay.
a bright red color, then it will, yeah. Okay,
Okay.
this was the dissection. Generally, this can be asked in the exam, dissection. Either this image they'll give or they'll give a CT image. Okay,
City image is good.
CT image is good, yes. So as here you can see there is a pericardial effusion here also. But since a lot of septates strands are there, they're telling it as an exudative pericardial effusion. Okay. So next one is the speckled
Myelidosis.
amyloidosis. I don't know, to be frank. This is always confusing.
No, you just have a huge heart.
Mm.
Actually, it is not to be seen like this. You have to see
Because
the
it's brighter.
yeah. There has to be restriction actually, and this is not a very good picture. It is much more like speckled is really speckled.
Yeah.
Okay, if you see, it's really shiny. Yeah, it is really shiny. Just
Yeah, I've seen a heart
speckled.
which will be very shiny and all.
Yeah. It's not a very good picture, but the thing is that there is very much good restriction in it.
Mm.
You have to obviously you can see the chamber is very small out here because
Especially
of
the
that.
ventricles are so small.
Mhm. Okay, next constrictive pericarditis.
This I don't know, to be frank. By echo, I'm still not learned how to diagnose a constrictive pericarditis.
I have no idea.
I think we'll leave
So
it.
RV dilatation is important in this case, and this one, no, and your septal deviation during your what do they say systole.
But diastolic, here they mentioned is diastolic cardiac collapse. Okay, diastolic cardiac collapse is a more of a picture of a tamponade. If a diastolic cardiac collapse is there, it's a tamponade. Repair it immediately.
You have to treat tamponade.
Actually, they should give a Doppler waveforms. I've seen somewhere them showing the Doppler waveforms. I don't know where exactly.
Forget it. This is confusing.
We'll leave it. I think constrictive pericarditis will not bother. We will rely on X-ray for time being.
Now we'll share some image. We'll okay, Takotsubo.
Takotsubo. Okay, there's the apical ballooning is there.
We have to rule out by doing all the angiography, etc.
So this is this thing scan, this thing thallium scan. So always there are two images will be there. Okay, first above images will be under stress, below image will be under rest. Okay, and it will be from apex to base always. Okay, I think full image is not there in any of this. It's okay. This one only. You can see here. This is from apex to base. Okay. This is our stress. This is rest. As you can see here, in this hardly any filling is seen. If you see the first one. Okay, but rest everything is reversible. Okay, filling is good. So it indicates that patient might benefit from intervention. Looking at the first image and second image. Okay, nothing is there. Here it is completely filled during rest. So during the stress, some angina component is there. It is due to some stenosis or something. It will benefit from. Here a second image, if you see, here nothing is filled in apex. Here it's completely filled. Here nothing is there. Here it's completely working fine. So based on this, patient will benefit from intervention. There are 3 ways generally they'll give. One is short axis wave, another one is horizontal long axis, other one is vertical long axis. The 3 waves that will be given. Basically, you'll be looking at these things. How it looks at stress. See in this, in the stress, this is not filled, whereas at rest, it is filled. So you
How can we remember this is apex, this is base?
Actually, it is like a hard regular images only. But I think if this whatever is there, this is the apex. Okay, it will goes on increasing in the size. Okay, it will increase in the size gradually in that images. Apex means edge of the tip of the left ventricle.
You have to remember, like this one, from where you are seeing actually.
Yeah.
To imagine that.
Oh, how many imagination I have.
You could have become
We'll
an
keep it
artist if you have so much imagination rather than doctor. Okay, I know it's difficult, but I think you have to practice 1 or 2 scans, then you'll be able to understand better. At least 1 or 2. Okay, so SPECT is done. When the indication of SPECT?
Indication of what?
With the SPECT scan.
Assess the ischemic.
Or previous MI. If the patient is having previous MI, you can go for this one.
With ongoing angina.
Yeah, ongoing angina. Any chest pain or something complaining patient.
This is second line, no? After CT angio, this will be, if CT angio is not
No,
there.
CT angio for the first time. But for
Okay.
patient comes first time, we have to do some CT angiography. And
Okay.
if the patient comes, if the patient is having history of previous MI and again come, then we have to do this thalidomide scan, that aspect. It is
Then.
better than dobutamine one.
Okay. Okay, we'll go to the next one before we go mental.
To finish.
Oh, finished? Hey. Okay.